afternoon to you all. When PC asked me to talk on some subject, I said I'll talk on points to ponder, because whether you are a beginner or whether you are a champion, when things has to go on right or safe, you have to remember your basics then and there. See, nowadays more and more minimally invasive surgery, all endoscopic surgeries have been coming to vogue. And surgical success depends on whether you have to be beware of certain things and you have to be aware of certain things. Beware, these are all the things happen in endoscopic surgery. The wrong level surgery, probably the more and more experience, your incidence may come low, but still it happens. Wrong level, recurrence or persistence of pain, dural tear and nerve injuries. Prevention is always better than cure. It will be more useful for the beginners. Between surgery and success, there is only one word. There is a selection. It is very, very important. How to select the patient and how to select the procedure. You have to be aware of that. On that score, indication, you have to any minimally invasive surgery, you have to be strict on your indications and no compromise on investigations whatsoever needed. And the procedure, you have to decide what you are going to do. And equipments, you have got an adequate and full equipments as much as possible. And expertise, you must know your limitations, when to touch which case and complicated cases. Whatever surgery you do, patient do not bother about what you would do, but they bother about the results. So systemic symptoms and signs are very, very important. After all, patient bothers his symptoms to be relieved. And it is mainly by the clinical examination. Talking to the patient is very, very important. And you talk to the patient what type of pain has got, which will give you some clue, source of pain, which you have to address. And sometimes patient general status, for example, a chronic diabetes, probably you have to make the patient aware of, because even after surgery, patient may have a pain because of neuritis and not due to disc. And if the patient had to go previous surgery, you have to know the full details about it. So selection of the patient is very, very important. When the next is all the three major investigations are available: X-ray, MRI and CT scan. And of course, choice is yours and not the patient. Do not make a compromise. X-ray must be good, both AP and lateral. If necessary, special views, dynamic to know the instability. And MRI, recent. More than 3 weeks, better take a MRI again, because patient may resist. Sir, I have taken recent MRI 6 weeks back, but don't depend on that. And next one is always you, an operating surgeon, must read MRI rather than totally relying on the radiologist. CT scan is a must whenever you do a rego for surgery. Now, X-ray do not underestimate, because segmentation levels is wrong level is majority of the common, because you miss 6 lumbar vertebrae or 4 lumbar vertebrae are there. Segmental issues, unless you examine and clinically correlate, you may miss the bus. And next is you have to interlaminar window. Assessing the window is very, very important, because it is more of your working area. You know how much of bone work you have to do. It all depends on what is the area of the interlaminar surface. And it gradually increases from proximal to distal, whereas the transverse foramen, it is intervertebral foramen, gradually increases from distal to above. As a surgeon at Distendo, not only we are interested in the posterior, you look into the lateral also, whether the canal is compromised. Even you can find out in the X-ray if it is going to be an osteophytes. Probably you may have to address that also. Then coming to the CT, be aware that Boney Islands are the signals. When a fellow is coming, you are going for a second surgeon. The guide is only the signal light is Boney Islands. Whatever bone is there left behind, you start your work there and then proceed with the scary area. Otherwise, you will be in trouble. So in those lines, CT is very, very important. And when a situation is like this, where the ligamentum flavum is sometimes will be calcified, you have to identify only by the CT. If not, when you plunge in, probably you may injure the dura and now damage may be there. And sometimes even a 3D reconstruction may be necessary when you want to do a rego. So revision surgeries and stenosis, better always go with the CT scan if possible. Then with the MRI you use for a precise localization, do not search for the disc. Identify the lateral margin of dura. Whatever method you do a disc surgery, always identify the lateral border. Don't go and search the disc initially as and when you enter into the epidural space. Identify the margin and localize where exactly the disc. You should not search on the table. Preoperatively, you know where exactly the disc is there, and then see and open. In those days, when we were there in 1980s, we open and see. Many times we open for a disc, it happened to be neurofibroma, because in those days we get a myelogram only. Now we have got a radiological advancement, we have got an MRI, so see and then open again. Don't open and try to see whatever pathology is there. Everything can be seen prior to surgery. And then now coming to the persistence of pain. Sometimes you have a situation like this, 2 or 3 discs are there, you operate on one disc, patient may not have a deal of symptoms. So in this situation, correlate clinically, do whatever it is, root block or EM studies to localize exactly the source of pain and then decide. And sometimes you have a double source. You have a disc with a fragmented disc, which is sequestrated. You might have removed one piece and left behind another one. So read carefully your MRI, see all the 3 disc removal, otherwise you will have persistence of pain. So see and open, do not open and see. That policy is almost over now. So for example, this is the case where you get 2 pieces, 2 separate pieces, sequestrated one, and this one you got 2 separated pieces separately. So don't remove one, look for any free pieces always inside so that your surgery will be complete, patient will not have any persistence of pain. Then coming to the procedure, plan yourself what to do, be precise where you are going to work on it, and know your limitations. Because you are confident, don't venture too much on in the initial stages, you cannot do a safe surgery. So what you can do, you know your limitations. Anticipate the problems on the table in that particular case. What problems you anticipate in that particular case so that you will not get panic while entering in. And be ready for alternative procedures. If you are a beginner, if you are not able to complete the surgery, do not hesitate to open and get rid of all other open instruments. It takes some time, but doesn't matter. You will complete the surgery. In these situations of medical legal problems, safe surgery is more important than not incomplete surgery or coming out or your ego. So in initial stages, do not hesitate to revert back to the open surgeries so that patient safety is very important. Then coming to the equipments, a good C-arm, good suction is very, very important. Sometimes it may not work, it will spoil the show. Proper and adequate instrument is necessary, and it is a teamwork. You need a team, otherwise your burden will be more. The fellow will be, suction will be on, and then the monitoring, C-arm technician, what position you want. So all these things is the teamwork. If the team is not good, probably the onus is there on the surgeon and you will not be able to complete. So, and materials to meet untoward incidents. For example, a dural tear is there, you should have a zero silk. So otherwise you go and ask in a different setup, they will ask number 1 is there, number 2 is there, probably you will be in trouble. So you always have a materials to meet the untoward incidents. So expertise, know your limitations and the setup, also very important. To start with the simple, straightforward cases, to begin with L5 S1 disc. Then you can go for L4, L5. Then you can go for stenosis. Then you can go for a 2 level. It is a step ladder, you have a learning curve. Revision, unless you are able to find out the cause of symptoms or source of symptoms, do not operate, because you will be added in one of the list of the failed back surgery. So revision cases, pinpoint the source of pain and then go and address the problem. Otherwise, for the sake of doing it, you will be also one among the list. And know about the previous details, what the previous man has done. If the records is there, try to have a CT if possible. And do not hesitate to talk to the seniors and for ego. So to conclude, indications you must be very strict, investigations no compromise, pre-plan your work before you going for surgery, equipments must be educated, everything must be in order, and expertise and analyze yourself, your limitations, what you can do. So as I said earlier, there is only one word between a success and surgery, there is a selection, and prevention is always better than cure. Each case is different, even now for all the seniors. So that's why surgery is interesting. Do not take it lightly. Thank you once again.